Me again. So welcome so much to our panel. I'm really excited to get to talk with you all. Those are fabulous socks. You were giving Scott Gottlieb a run for his money on the sock front. Don't know if Scott's in the audience.
This is my gratitude that the FDA changed the rules to allow gay men to donate blood after a blood ban for air.
All right. So I'd like to ask each of our panelists, if they don't mind, just to introduce themselves and tell us a little bit about what you do.
My name is Yele Aluko. I am a former cardiologist, practiced for 22 years, up until 8 years ago when I joined Ernst & Young. I'm currently Chief Medical Officer at EY. My work spans the industry value chain, clients in the payer, provider, public health, life sciences sector. And I'm also the director of the EY Center for Health Equity.
Wonderful. John?
Great, Meg. Thank you. It's nice to see everybody. I'm John Crowley. I have, for 25 years, had been a biotechnology entrepreneur. My journey started in the late 1990s when our two youngest children were diagnosed with a rare form of muscular dystrophy known as Pompe disease. It launched me into this world of science and medicine where I had no training. Built companies, one company, Amicus Therapeutics, for nearly 20 years. And earlier this year, I stepped down from CEO. And so your question, what do I do now? I get this from my kids. What is it exactly you do now, Dad? I am the president and CEO of the Biotechnology Innovation Organization, or BIO. And we are the world's largest and leading organization representing the biotechnology industry on policy, advocacy, communication. And I think in part my job is to perhaps be the chief evangelist for biotechnology.
And what John isn't telling you, and many of you probably know, is he was played by Brendan Fraser in a movie about his family's story.
Great exaggeration in Hollywood. Had they picked an actor 6'5" to play me, but that's okay. Other than that, the movie was perfect.
Kody.
Good morning. My name is Kody Kinsley. It's my pleasure to serve as the Secretary of Health and Human Services in North Carolina, where we have been on a long journey of investing in what drives health. We have been doing work around social determinants of health that I think we'll be talking a bit about this morning. We achieved Medicaid expansion in a bipartisan way after a long decade battle. And then we have done this effort to forgive medical debt for 2 million North Carolinians, valued at about $4 billion. And so trying to, thank you, take away the barriers that get in the way of healthy outcomes.
Just a quick question. The medical debt, how did you do that? Was it by buying up the debt, like the models that we've seen before?
Actually, no. We leveraged state-directed payments as part of the Medicaid program. We gave each of our 99 acute care hospitals in North Carolina the option of opting into that program, and all 99 of them said yes. So they were able to draw down state-directed payments, and then they were able to forgive debt. And I think more importantly than actually the debt forgiveness was prospectively raising the floor on charity care in the state and making it so that individuals could be deemed presumptively eligible for charity care at no effort for them. And so it's kind of an automatic thing for them. So it's really exciting, I think, changing the game to try to get that debt that is rarely collected anyways out of the way.
Right. Super interesting. Papa.
Sure, Megan. So good morning, everyone. And just maybe a question, why am I here? I actually run a company in New York called Royalty Pharma, and with an amazing team over the last 28 years, we have been developing a new way of funding innovation in life sciences that didn't exist before we started. And the business started by us acquiring royalties from universities, research hospitals, monetizing them, giving them an upfront payment. These institutions would take the money, build buildings, fund research. But over time, the business model changed. As we grew and became big and diversified, what we also started to do is to fund clinical trials for biotech and pharma at scale. So over the last decade or so, Royalty Pharma has invested about $25 billion, actually a bit more given what we've done this year, funding the ecosystem, and about 10 billion of that has been in products that are not approved, where we're taking risk, funding clinical trials for biotech, and we end up with a royalty. The reason this is new is because for years the industry was being funded with more conventional ways, equity mainly. When you don't have revenues, you cannot use debt. but mainly equity. And since Royalty Pharma started, what we're doing now is providing capital to the ecosystem and end up with a small royalty that's not equity dilutive. And I'm also involved in another business that I started in 2009 where we actually lend money to the biotech industry at scale. So we can get more into the details of this later, but that's essentially what we do. And it's very exciting because the business has become more relevant in this industry. We're investing a lot in data because in addition to being a capital provider to the companies, what we want to be is to be a partner that can add value by actually sharing with them data on development of trials and other things.
One of the questions I've had about your business is something that we saw in the poll at the beginning is just the transformative nature of GLP-1s, the Ozempic class. How much of what you're looking at in pipelines right now has to do with that class of medicines?
So we are looking at it for sure and having discussions with companies that are developing the second and third generation of those drugs. And as everyone in this room knows, it takes so much money to develop drugs that having a part of the funding be a royalty can be very attractive for these companies. So we're actually looking at those drugs and just thinking back of 3 decades almost of investing in this. For example, we became very involved in anti-TNFs, so drugs like Humira, Remicade. And I recall that when all of this started, there were a first wave of drugs that were launched, like Embrail and others. Eventually, newer drugs, Humira was one of the more later ones that was launched, and we got involved, and that became the biggest drug in the world. So I think it's a very exciting time for, obviously, obesity and other benefits that these drugs have. But I think we haven't yet seen what's to come, and it's really exciting, the things that are in the pipelines now.
Yele, as you advise executives in the healthcare space, what are you hearing from them, and what is your main message right now as we're heading into this transitional period about what the sort of biggest issues they're going to be grappling with are?
Well, fundamentally, we need to understand that we exist, hopefully, to provide care to our populations. And we have to understand that the health industry is, for lack of a better word, is dysfunctional. And we have to do the best we can to drive value within the context of its dysfunction. When I say dysfunctional, it's overtly expensive. That was mentioned today. The amount of waste that comes through the health industry is unacceptable, about $500 million a year of waste. So,
and what is that waste? What is that waste?
Unnecessary procedures,
okay.
Avoidable admissions, fraud, and other line items. So we have to, irrespective of what type of government we have, the fundamentals of the industry are broken. And we have to look upstream to understand why that is. Mandy Cohen talked about population health and also talked about prevention. Prevention is a situation in US medicine that is most oftentimes an afterthought. And the reason why that is the case is because we live in a fee-for-service world where we're paid to do more as doctors. And the context of prevention is not well understood. We talk about primary prevention and secondary prevention. Primary prevention to prevent the onset or delay the onset of disease, and secondary prevention to prevent the same disease recurring. So for us to actually move the needle, we need to be proceeding towards the context of value-based care to dismantle the current infrastructures that support fee-for-service and to pivot to fee-for-value. Forward-thinking organizations, clients of ours, understand this, but nobody gets paid for prevention. So investments, those that can afford to invest in prevention, can afford to invest in population health strategies, are the first to market movers that when value-based care does become a thing, will be positioned to be most successful.
John, as you're approaching this new transition, representing the entire biotech industry, what is top of mind for your members right now and the sorts of conversations you're having with potential new administration?
I think, Meg, the first thing is to remind everybody, why do we care? Why do we care about an industry like biotechnology that really is an entire ecosystem, a very uniquely American-born industry that's only about 48 years old when the first scientists and venture capitalists came together to form a company that we call Genentech today. So, why do we care? Of course, we care for the public health. The potential to control, to prevent disease, to alleviate an enormous amount of human suffering around the world. We care about it for economic security, a productive and healthy workforce, but it's also a matter of national security. That the ability to make newer and better medicines to prevent disease in the first place is a matter of national security. It is a strategic asset to the United States and our allies, and ultimately the entire world, that the world is a better, safer, healthier, and more prosperous place when the United States and our allies lead in biotechnology for the benefit of the whole world. And so then we think about, when I first came into the job about 8 months ago, I laid out my 7 core strategic priorities. I promise I will not go through them here. But the 2 at the top of the list, and not surprisingly, I hope, are innovation and access. So when we think about innovate, we've traditionally thought about the development of biotechnologies, for instance, in kind of neat swim lanes, if you will. That we've got science here, medicine, regulation, patient interests. And what we realize is actually a circle. And what I try to describe as a virtuous circle, where you've got the patient, the person, the consumer at the middle, and the heart and soul of everything. And about 70% of all new medicines originate in small emerging biotechnology companies, well more than 1,000 just here in the United States. But much of that research is licensed from our great academic research centers. It comes from the NIH, it comes from NIH-funded grants. That's kind of the special sauce of what we have. But drugs are developed in companies, and sometimes very small and sometimes very large companies. And it requires this whole ecosystem, the whole model, Pablo, that you introduced, bringing whole new sources, billions and billions of dollars of funding that it takes. And again, realizing this is a really hard business, right? Almost everything we try, no matter how much money we raise, buildings we build, Nobel laureates we hire, it doesn't work. It's hard, it's risky, it's challenging. But when it works and you go along that circle that involves everybody that it takes to control, prevent, cure disease, and eliminate suffering, rarely is it a cure. Oftentimes, it's meaningful improvements. So what we care about in that virtuous circle is opportunities to advance the science. We've never had, and Dr. Califf was right, I've never been more excited about the science in medicine. Right? When my kids were diagnosed, I had to scour the world to find 2 doctors who knew anything about it. Now, there are dozens of centers just in that disease. So the science in medicine is here. We just need to make sure we've got an infrastructure, an ecosystem that helps us in some ways get out of our own way. So making sure we've got resiliency of our supply chain to manufacture these medicines. We continue to have capital. We protect intellectual property rights. Make sure people don't abuse intellectual property rights. We reimagine the clinical trial and FDA approval and review process, introducing, and Dr. Califf has been an advocate for this, ideas like improving regulatory science, keeping to the gold standard, Bayesian statistics, adaptive study design, looking at each drug through a separate risk-benefit assessment. That's innovation. And then on access, the whole notion that simply making newer, better medicines is necessary but not sufficient. Janet Woodcock at FDA years ago had said that until we get to the point where the homeless person living under a bridge has access to the most state-of-the-art CAR-T cancer therapies, we will have failed. So why do people go without their medicines? Where are the economic barriers? We've gotten to the point where in many cases now with this complex and cumbersome utilization management practices at many insurance companies, a physician writes a script and it's a recommendation of the insurance company. We've kind of broken that sacred bond. So I've got this maybe crazy idea or vision that President Obama signed into law the 21st Century Cures Act 8 years ago. We need a 21st Century Access Act. Reimagine co-pays, out-of-pocket costs, the whole system, so there's no economic barriers, educational barriers, disenfranchised communities, women's health care. So innovation, access, those are the things we care about, and those are the highest priorities.
So change co-pays and insurance, but not list prices.
Well, so when you look at that, absolutely. When we start to look at list prices of medicines, nobody understands list prices. I don't. You get rebates and all these systems. It's so Byzantine and complex. Only about half of the economics of the cost of a medicine ever go to the innovators and the developers. The rest of it is lost in the system where You've got the PBMs and wholesalers and pharmacies. We need transparency in that. We need to de-link any of those intermediaries from, they have this massive perverse disincentive that the higher the price of a medicine, the better it is for the middlemen. So let's address that. And there's leadership now in Congress on both sides to do that. So the whole ecosystem we need to take a look at to ensure access.
Mm-hmm. Kody, I'm going to ask you to kind of digest both of what we just heard in terms of the dysfunction in the healthcare system, these incredible advances we are seeing in the science and in medicine, and in the lack of access that a lot of people have to care. What are you seeing in your state in terms of successes on those measures, but also what can be improved?
So to start, I think I'll say, the frame at which I approach this, which is that I'm a bit of an oddball Health and Human Services Secretary, in that my background, I was the COO, CFO of the US Treasury down the street for both President Obama and President Trump. And so in coming into this role, my real drive, I call myself an operator with a policy problem, but my real drive is how do I get more marginal value from every single dollar I spend? And how do I do it every day at every step? And I think in the framework that Yele outlined beautifully is that we have got to optimize within the healthcare system itself, right? There's too much process, there's too much administrative waste, so the incentives are wrong, and moving towards value-based care, et cetera, et cetera, et cetera. But that's only going to make things better to the point that we walk in the front door, right? We still have more folks coming in the front door, so how do we then move to prevention? We've got amazing innovations happening in the drug space that are going to catch people where they are, because we can't just, all this talk of like, we can change the health of an entire generation just by doing it all at once. We have to treat everybody where they are regardless in this moment. This is why I'm excited. I'm very bullish about GLP-1s. North Carolina's Medicaid program was one of the first few in the country to make the choice, right? We still have a carve out where weight loss drugs aren't covered automatically in Medicaid programs, and we chose to cover it because most people think about Medicaid and they think about moms and young children. I think about long-term care costs that are out of control and growing rapidly as folks age, and when people deplete their personal resources, Medicaid is the only game in town. And North Carolina is the buckle of the barbecue belt. I'm sorry, friends, we have the best barbecue in the country. You can tweet that or whatever you do now, I don't know. And yet 70% of the people in North Carolina are overweight or obese. Now, I want to be able to do all the great things the GLP-1s offer as part of that, and I see that as a smart investment. And I don't buy the argument that because the PBMs and everything else are broken or whatever, the general statement, that we should wait on it. And I feel like that's been the general argument right now, and I'm not interested in holding back good access to drugs for folks that are going to move me to a marginal cost that is better. But yeah, we have to get upstream. And in North Carolina, our big push here, and I credit Secretary, I will forever call her Secretary Cohen because she was my predecessor in North Carolina, but Mandy, who really led the charge in the country on establishing our Healthy Opportunities pilots. We launched them in 2022. And this is the first in the nation effort to take what is classically Medicaid dollars and pay for all the other things that will help keep you healthy before you walk in the front door of the healthcare provider, because so much of that first order prevention is far outside of the health system. It's leveraging civic organizations, faith-based leaders, building nonprofit, community-based organizations in regions across North Carolina to help give people access to the fundamentals that promote health, food, housing, transportation, keeping people safe, supporting them with access to employment, et cetera. And 2 years in, it's working. We have found in the first roughly 20,000 people served, about 300,000 services provided, by and large food, a, first off, statistically significant report that their social needs are met. Second, a statistically significant reduction in emergency department visits, in hospitalizations, and net of costs, a savings of about $85 per member per month, which is an insurance cost, is real. Now think if I could extend that to the 2.8 million people that I have in my Medicaid program across the state. And we're just getting started. And I know that my next marginal step after that will be great. We're putting a lot of Medicaid dollars into food, right? If you were to look at the per food box cost of that program, you'd be like, are there truffles in those boxes? Like, what is going on? And that is because, I always jokingly say, like, who here loves medical billing? Come on down, and that's essentially what we're taking to the community-based organization. So we've got to continue to streamline that. But at the same time, we've got SNAP and WIC, fundamental programs that help support food access in this country. And yet I know today that if I had perfect enrollment in those programs, the size of my SNAP program would double. We're not getting people in the door, which, I think those are real policy conversations about, the administrative cost of people applying and all that, but then we're leaving a lot of money and opportunity on the table that are going to save money in the long run. So I'm excited about this path, and I think we're bullish on it, and I think we've got a lot further to go, and I hope that we will continue down that path.
How do you get those people in the door? What does that require? Does it require more funding, more personnel, a bigger,
Well, we saw it during COVID, actually. When we dramatically reduced the burden for application and did presumptive eligibility on the SNAP program, it worked just fine. And we've got a lot of the tools in place today. I mean, right now I am able to look at your SNAP application, and by virtue of the income information that you're enrolled there, I can put you on Medicaid automatically because of E14 waivers, blah, 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 blah. North Carolina has enrolled 578,000 people in Medicaid expansion in the last 11 and a half months, like full speed ahead. I can't do the reverse. Different rules, different appropriating committees, different departments that manage these programs. We need to look at these fundamental resources and stop thinking of them as the handout and more of the springboard, and how do we align the rules across them.
And just briefly to follow up on the GLP-1 thing and the coverage within Medicaid, is it right? Did North Carolina just stop coverage, though, for government employees of GLP-1s?
Yeah, we were an interesting state. So I do not run the state health plan. I run the Medicaid program. But I think it actually highlights a great thing. So the Medicaid program gets a really phenomenal rebate relative to the state health plan. The state health plan, for its own reasons, made the decision that it would not cover it. And so the state employees that are not getting covered were doing the work to then cover it for Medicaid and making it accessible for folks. But I will tell you, it is, when you look at the total net cost, it is not going to be my most expensive drug by far.
Interesting.
What is your most expensive drug by far?
Dupixent.
Dupixent. Interesting. Okay. Pablo.
I was just saying, I haven't seen any front page news about Dupixent. Sorry. It's wild to me that GLP-1. Okay, go ahead.
I'm going to follow up with you on that because I actually think it's really interesting. Dupixent is an anti-inflammatory drug, right, for severe like skin rashes and asthma, COPD, I believe, made by Regeneron and
Great drug.
Sanofi. It's a very impressive drug, but apparently very expensive. Okay, we'll follow up on that. Pablo, one of the main themes that we're talking about today is trying to shift into prevention. As you're looking at what's available out there for you to help finance and to invest in, how much is the drug industry focused on prevention?
So it's an area that actually we don't get involved that much currently, because it's all about treating. The focus has been a lot in severe diseases, critical care conditions so far. But there's no question that on the prevention side, there's huge opportunities for us and for the entire industry in looking at data applications, I think, and changing behavior of the population, which should have a big impact. What we have done at Royalty Pharma, because the issue is, I see this ecosystem is incredible. When you look at the US, it leads the world in so many areas of life sciences, innovation, and medicine. One thing that all of us here need to really recognize is it's so difficult to replicate what this country has built over many, many decades that the US will stay at the lead for many, many years. The whole infrastructure of universities and hospitals that do research, impossible to replicate. And when you add to that everything else that exists that actually makes this so efficient in terms of innovation, I understand there's a problem of access to health, but in terms of innovation, the U.S. is by far the leading country in the world. But we do have a problem of access and prevention, and I think the problem is access to health. It's actually disparities in treatments, that when you look across the population, there's huge disparities in how people of different races, different economic classes are being treated. and also then health outcomes, which obviously come because of those two first things, access and treatment. And I think, the industry, and when you think about that, what really has to happen is that the healthcare providers now have to start to collaborate a lot with the companies that are developing the product to actually start to think much more proactively and think about prevention, because we will become much more efficient, and when you think of dollars spent, if we can be much more successful in prevention. But it's a shift of mind that is needed in the industry to actually approach things from that perspective. And it's all about collaboration, and this whole summit that Milken has so successfully been created, and is all about collaboration. So we all have to figure out how we're going to solve these problems as a group. But I think prevention is really important and going to be critical in helping us with access and cost.
Bless you. Yele, this is something you've spent a lot of time thinking about. I think this sort of issue for the United States, where we are so far ahead in many ways in the science and the development of new products, but far behind when it comes to life expectancy, things we were hearing about in the previous conversations. What lessons can we take from other countries? Which ones do you look to that could have things that could help us?
So we have a very mature health industry, albeit dysfunctional, very expensive, reactive, but we treat conditions very effectively, expediently when they get to us, expensively. But when we look at the macroeconomic indices of efficiency of health systems, such as access to healthcare, integration of healthcare, focus on population health, access to health coverage, we all know that we do poorly when we're compared to our global peers in the OECD countries. Now, this insight has been available to us for 20 years, and we have failed as a country, and by extension as an industry, to pivot towards value. We have to be willing to address the elephants in the room, which are upstream drivers, and Kody spoke eloquently to this, that prevention is succeeded best if we address the social determinants of health. One main driver there is access to healthcare, health insurance. Countries across the ocean like Japan, Singapore, Korea, and some of the Nordic countries, Denmark, Norway, the United Kingdom, they have a focus on population health, a focus on health insurance for all. It doesn't necessarily mean that that is Medicare for all, but a combination of commercial government insurance that makes sure that all citizens have access to care. Now, what do I mean by access to care? Access to health literacy, access to preventive modalities, so that you can delay the onset of disease and you can identify disease early. But very importantly, healthy behaviors. Now, absent of that, we sit in a country here where, when I was practicing cardiology, it wasn't unusual for me to do an interventional procedure on a person who'd had a heart attack, put a stent in, and on rounds the next day, the patient's gone downstairs to smoke. So this is not fallacy. This is not unusual.
And maybe they'd run into their doctor outside.
Well, that too has happened. So when you have a culture that waits for patients to come back with the same problem they left you with a year ago, and you get paid again to do the same thing you did, and you then sit back and wait for them to come back, because they come back, you then realize that you are within a very distorted ecosystem of understanding and execution of therapy. The first speaker today demonstrated the lack of awareness of the significance of the lack of health literacy that we have in the country. So we have a population awareness gap. We have a treatment model that does not foster prevention, because we're not paid for that. But we have upstream issues where we stand in the position of being the only country in the top 14 OECD countries that do not provide universal health care. And there are significant repercussions towards that. We know this to be a problem. We just haven't mustered the political will to address it. And the question is, why? Now, some people think that there are more black and brown people that are uninsured in America, but there are actually more Caucasians that are uninsured, numerically. The percentage of black and brown people that are uninsured is higher than the percentage of Caucasians, but when you look at the numbers, it's more adverse for Caucasians. There are more Caucasians that are exposed to the adverse social determinants of health. This context of health disparities is thought to be a racial conversation. It is an American problem because thousands and millions of Caucasian Americans are experiencing suboptimal health outcomes. And this is all because we don't focus on population health. We get caught up in special agendas and the implicit biases that we are unwilling to attack upstream.
Well, there was a lot you put out there that was really interesting. But John, just over to you, thinking about some of these things in terms of the adverse determinants of health. I'm thinking also about the conversation that is being had a lot more, particularly through this election season, and the health conversations about our food supply, people's access to healthy food, ultra-processed foods. Just thinking about bio as an organization, we often think about drugs, medicines, but how much of bio also encompasses food companies as well, the companies that participate in agriculture?
So at Bio, we cover, apparently I broke my microphone, so I'll use this. At Bio, we cover not only human health, we also cover agriculture and environmental biotechnology. So agriculture is incredibly important. I said I wouldn't say all of them, but I think I'm working them in. One of those 7 strategic priorities for me was to address food insecurity. And with that, I think there's a role to play, an important role for biotechnologies. I'll give you an example, Meg. The old maxim, an apple a day keeps the doctor away. About 40% of the apples that we grow and distribute here in the United States get thrown away because they go brown, they go rotten. There is now a remarkable and a safe biotechnology from one of our 1,000 member companies in the agriculture space that prevents browning of apples. So what that could do for school budgets, to address to other means for nutrition for children, and what that could do certainly for apples that are loaded with vitamins and nutrients and fiber, is just one example of what I think biotechnology can do in the agriculture space. And then I think even just to take it back to human health for a moment too, yes, behaviors, environment, all the things that we know and we've talked about, we've made improvements. But we can't control everybody's behaviors. Unfortunately, we can't fully control the environment, and for many disorders, the genetics are loaded against so many of us. And you take an example like a human genetic disease, a monogenetic disease, like the one my children were born with. There are no behaviors, no environmental changes that will change the outcome of that disease. So while prevention can be routed, or grounded rather, in change of behaviors and access to food and nutrition, incredibly important part of that. In many cases, though, you either can't affect that or you just have no ability biologically to affect it. And this is where medicines are not just, my God, somebody's got a late-stage cancer, we need the most advanced biotechnologies. Sometimes we do, and thankfully we have more and more tools in our arsenal to extend and enhance human life. But we can also think about this as control and prevention, so that when somebody, for instance, is born with a human genetic disease, if we can intervene early, they can get state-of-the-art medicines, and they have access, everybody has access to those medicines. We can prevent the cascade of events that lead to all of this disease and suffering and ultimately mortality. And you don't need to just look at rare genetic diseases, look at cardiovascular disease. Nobody dies, and generally nobody suffers, if you have really bad, really high LDL cholesterol, or nobody dies because you've got a plaque buildup in your arteries. you die when that plaque breaks off and it causes a heart attack or a stroke. So medicine, statins that have really changed the course of disease outcome for so many, that's prevention as well.
You know, Kody, one of the things that I think a lot of people are feeling, and we saw in the previous two conversations in the presentation, is just how disconnected a lot of people feel from the systems there to try to help them, from government systems, from support systems, from the medical system. They don't feel like they're getting good care. It's really hard to see a doctor sometimes or get to spend very much time with them. It can be hard to find good sources of information or know what sources to trust. How are you approaching that from a making people feel part of things perspective and a communication perspective to make sure people are getting good information and feel like they are being cared for?
Well, I think maybe my maxim on this front is it's amazing what you can get done when you don't care about who gets the credit. And I think that the other piece here is that we're going to fix these things at the speed of trust. I think this is one of the exciting parts of our social determinants of health, our healthy opportunity pilots, is that sure, it starts out with a community-based organization that was most of which are already in these communities doing this work already, that actually now has sustainable funding, now has lasting employees that are able to stay there, do their good work, that are taking food boxes to people's homes. And it started out as a food box, and it became a conversation, it became a relationship, and then it became, oh, I see you're also struggling with some domestic violence issues. Like, can I help get you connected to someone? Or, oh, you didn't know that you could get a free primary care visit, or, oh, you didn't know that we expanded Medicaid on December 1st, and now you're actually going to be eligible, so you should apply, so let me help you apply. I mean, I think the power of these community health workers and whatever we want to call them that are doing this kind of peer work on the ground, and it was a group of us having dinner last night, and one of the individuals there was talking about just the power of food to build trust. And I think we think about food as an enabler of health, but we also know that food is something that many of us were texting earlier, like, should we get drinks later? Should we have food? We're like all excited for the opportunities to build and bond together here at this meeting over breaking food or glasses. And I think in the same spirit, as much as we can get the health system out of the cold, scary doctors' offices that are heavily regulated and get it more into the 80% of what drives health in the community with civic organizations and faith leaders, that's great. Now, if government's bankrolling an aspect of that, fine. Do I need to have my sticker on it? No. The outcomes are what I want to pay for, and the improved health.
All right, we're getting down to our last 3 minutes, so I'm going to ask each of our panelists to think of a closing thought they want to leave folks with to discuss as they break bread or hopefully not break glasses, but I guess if you're having a really fun time.
Toast glasses.
Toast your glasses later. Pablo, let's start with you, closing thoughts.
Yeah, I think, as I said before, we're in really exciting times for our industry, our ecosystem, with incredible innovation. We have a lot of problems. Talking about prevention, one of the things that comes to mind that we've been involved with and I'm very excited about is the Institute of Health Equity Research that I helped create at Mount Sinai in New York, which is a very important health system in New York. And now Royalty Pharma has started to work with them by providing a lot of data that we have access to that we use for our own purposes, and a team of biostatisticians, and really work on all of these topics of prevention, access to health, and we're doing a lot of research with Mount Sinai on access to health, disparities in treatments and then disparities in outcomes. And I think, there's really, what I'm starting to see in the 3-4 years that we've been involved is that you can have an impact in the communities by actually taking that kind of approach, but it's partnerships, it's collaborations, us with a lot of data providers that work with us, and then Mount Sinai, which can then really disseminate the knowledge and the data and succeed in fixing these issues that we're facing. But
let's wrap around this way, Yele. To you next.
So I think that we need to be able to develop more intentional and deliberate advocacy to address upstream issues. What hasn't been talked about and what isn't very well understood is the context of political determinants of health that drive the social determinants of health, executive orders, judicial orders, distribution of resources, and so on. Advocacy that positions the health industry and all the stakeholders in the value chain to pivot away from reaction to prevention, value-based care. a cultural shift. Talked about the GP1s. There's indiscriminate use of it right now because there's populations of people that, from healthy choices, have found an opportunity to continue healthy choices and use the drug. It isn't your responsibility to police that, but the whole value chain enables ongoing bad healthy choices and commercial benefit secondarily from it. So all the problems are intertwined, but can be arrested if we have upstream decision makings that are responsible and in the interest of population health for all Americans.
Are you optimistic we're going to have those?
I'm always optimistic. To keep, as we say, the Carolina Panthers football team, you keep pounding.
Okay. John?
I am also an eternal optimist. As a Notre Dame fan, we always say, go Irish. But I will tell you, when we began this journey into this world of science and medicine and healthcare, somebody once told me that nature is not cruel, just brutally random. And, you know, again, there was very little hope. And I think the days of a doctor telling parents or children caring for an elder with Alzheimer's that, I'm sorry, there's nothing we can do. Enjoy the time you have. That's just not acceptable anymore. And it's not acceptable because we really are now just coming into this dawn of the golden age of medicine, where there are so many technologies that have the ability to change human health, whether it be prevention, control, cure. I used to say, boy, if I can just get the smartest people in the world in a room and solve this disease, we'll be in a better place. We couldn't do that. Increasingly, we can do that, but we keep getting in our own way. We're not finding ways, well, where are we going to manufacture it? What's the regulatory paradigm going to be? What endpoints are appropriate? How's it going to get paid for? So to me, incredibly optimistic about what's going to be this next third quarter of a century of biotechnology and science and medicine. Let's just make sure we get out of our own way in some cases.
I'll be quick. North Carolina has a Democratic governor, a supermajority of Republicans in the legislature. We expanded Medicaid. We invested nearly $1 billion in behavioral health. We've done our healthy opportunities pilots. We've totally revitalized the way we do mental health work in North Carolina, all in a bipartisan way. And I think the fundamental as to why we have been able to get that done is because everybody likes saving money. And taking the efficiency argument to task is the bipartisan path forward, and that we need to continue to push forward on with health.
All right, and I'll just add my last little spiel, which is please think of the media. When you are thinking something's wrong, you're seeing something, communicate with us. My email is meg.tirrell@cnn.com. Tell us how things are going. We want to know. So please think of the media as you're encountering all of these things that you do in your daily work. Thank you so much to our panel.
Thank you.
Thank you so much. Nice to meet you too.